let's turn our attention, Nizar, to we know that we sequence our drugs. We know that we have potent drugs that produce significant qualitative and quantitative benefits for patients. But one of the challenges is that a clinical trial defined disease progression may not be the same as clinical disease progression that we see in our practice. RECIST criteria are helpful, but certainly are not consistent with what's happening clinically with the patient, because oftentimes that's radiographic progression without any change in their clinical situation. So one of the things that we've not done a very good job of is really talking about when we should decide to switch therapies based upon progression. So help us understand in your practice what constitutes progression, when do you use radiologic and imaging, clinical, and what is your decision making when it comes to switching from a treatment to a second line treatment?
Bob, this is an excellent question, and I think you put it succinctly. We do not have a good system to assess benefit or response to therapy. And obviously the most robust, the most important, most relevant primary endpoint for any clinical trial, especially in oncology, is overall survival. But when we do not have agents that can achieve that primary endpoint of overall survival, we rely on progression-free survival. But that's a slippery slope because, again, it's arbitrary. We went through 2 iterations of RECIST version 1 and then 1.0 and 1.1, and we still do not really think we're not satisfied. So I looked at this question of progression, in 2 different, crystals, if you want. One would be if a patient is on a clinical trial. Unfortunately, we are bound by the clinical trial, especially if it's industry-sponsored trial, to follow the response criteria, which is RECIST version 1.1. So for that patient, if that patient meets the criteria of progressive disease, a new lesion, or there has been an increase more than 20% in the sum of the longest diameters of the selected target lesions, which is the criteria, then that patient has, by definition, progressive disease, and according to the trial provisions, one will need to change therapy or take them off protocol. But in practice, actually, if I'm treating a patient off protocol, I don't really apply. And I know we all have different ways of treating our patients off protocol than on protocol. So if a patient is clinically benefiting from the treatment and has slight growth, even if that growth is 21% or 25%, but the patient is benefiting, there are no new lesions, the patient is not symptomatic from their cancer, I think, and they're tolerating the treatment very well, I think it's reasonable to continue with that therapy beyond that arbitrary 20% growth. Now, I think, obviously, symptomatic progression or clinical progression when the patient is having symptoms from the cancer, regardless whether the radiographic changes are there or not, I think that patient needs to have different therapy. If somebody has bone metastasis and they're continuing to have pain, and the pain is due to the metastasis, not to an osteoporotic fracture, for example, or something. If the patient is having night sweats, fever, chills, what we call as constitutional symptoms, those patients, even if they did not have that 20% growth, those patients are not responding to therapy. They need change of therapy. So I think, obviously, now with the immune checkpoints, which I'm sure we're going to be discussing, immune checkpoint inhibitors coming to the clinic, this field is now taking a new level of challenges where progression by RECIST is no longer accepted as one needs to change, because we know about pseudoprogression with the immune checkpoint inhibitors, and so many patients initially had progressive disease by radiographic images, but felt so well, felt much better compared to baseline before they started their therapy. And those patients rightly should continue therapy if they have benefited symptomatically, clinically, and then surely in some of these patients we've seen the radiographic improvement lagging behind the clinical improvement, the symptomatic improvement, and therefore we really need a new system to evaluate patients and evaluate the response to therapy, and that surrogate endpoint that we call progression-free survival, in light of what we know now about the way these immune checkpoint inhibitors work and how the T cells infiltrating the tumors can initially cause an increase in the size of the metastatic lesions.